I will come and talk.
All right, so we'll get to Andrew as well, because again, we partnered with Kidney Cancer Canada for this event as well, so it's a pleasure to see. He came all the way from Vancouver, so he looks pretty fresh as well. So good. Thank you, Dr. Kapoor. It's a pleasure for us to be here today. I just also would like to introduce Christine Collins, who's the Vice Chair of Kidney Cancer Canada. We have an amazing board of volunteers, and Dr. Kapoor is on that as well. And someone was saying to me today that we need to give you a pay raise. Give you a pay raise. And I was pointing out that nearly everything you do is for free. It's a huge volunteer, and it is true. And that's why you have the free lunch outside, because you actually couldn't afford to go out to dinner tonight. Where's Gord Evanon? This is Gord's joke, by the way. The only reason that we're hosting this event here in Hamilton today is so that you would make it on time. There's BST, there's Eastern Standard Time, and there's IST, which is Indian Standard Time.
And then there is KST, Kapoor Standard Time, and it changes from day to day. So you are. But today would not have been possible without Dr. Kapoor's initiative and encouragement that we are involved in this collaboration. And I think this is the way of the future, with organizations across the country combining resources together to serve kidney cancer patients and their families and caregivers and survivors. So we do welcome you here on behalf of the Board of Kidney Cancer Canada and the staff. I'd like to introduce you to Mona Awad, who is sitting here. She's there. Mona is the person you normally reach and call into. And she does an amazing job with us, and we're expanding every day, and I will be talking about that a little bit later on. It's so nice to see so many of you here and to hear so many of your stories. And how many consider themselves a survivor? Hands up. Wow, that's amazing. That is just amazing. Surviving, yeah, it's just terrific. And I heard some great stories over dinner. It's just fantastic. And I think there's a lot more hope on the horizon where we're going. As Dr. Kapoor is about to tell you, the advancements in the treatment of kidney cancer, and Dr. Ott is going to be doing this. There's some really exciting times. We're going to have a break. It's a great chance for you to connect and network. And I do hope you take advantage and come up and see Andrew and Christine and Mona and myself, Dr. Kapoor, in the break, and introduce yourself if we haven't already met. Thank you for having us here today. Thank you.
So there's, Dr. Hutt's here, thank you. And so we talked with Indian Standard Time, and look who shows up. Oh. Just, Dr. Hutt is one of the medical oncologists at the German Cancer Center, very involved in kidney cancer, prostate cancer, and bladder cancer, and just a fantastic guy. We tend to do a lot of repartee here during these talks, and so we'll try to keep it tame. I also want to introduce Ranjana Maloney. Ranjana Maloney is going to stand up here. She's actually the director of the Kidney Cancer Research Center. So basically what that is a network. Whoa, let me turn that down to the titch. Let me turn that down to the titch before I get blind. Let me turn that up. Yeah. I don't worry. That wasn't me. Kamal, would you mind seeing if somebody can turn that down just a titch? I don't know where it came from.
It's turned up a little bit, Dr. Kapoor,
Oh,
just because they can't see you on the screen.
Right.
Sorry about that.
Should I get my shades?
Yeah.
So we have this organization called the Kidney Cancer Research Center of Canada, which Ranjana is the executive director, and these are an amalgamation of all the medical oncologists across Canada, urological oncologists across Canada with kidney cancer. So any of you that are out of town or on the webinar, on the website, I understand it's going through Facebook as well. Ranjana is a contact person for any of those people across Canada, and if you need any help as well, you can contact Steve and Andrew, but also Ranjana is a resource for that as well. Lastly, I'm also going to introduce my staff. We have Liz, Shabi, Sarit, and Camilla. These are They work with me in clinical trials, and many of you are on a clinical trial for kidney cancer, prostate cancer, and so on, and they work here at St. Joe's in our clinical trials unit. And we will talk a little bit about that. We encourage most patients to go into a clinical trial because there's great opportunities for new therapies and that. And we can talk more about that through the talk. So, without further ado, I'm going to start. My patients have had surgery here, so sometimes it can be a little bit daunting and scary to talk about this, but we'll be factual about it and be optimistic about how much advances we've had in surgery, how many advances we've had in systemic therapy for kidney cancer, and how there's so much great hope for cure for kidney cancer, both with advanced kidney cancer and localized cancer. But we do see there's about 5,000 cases, new cases per year of kidney cancer. 3% of malignancies peaks in the 6th and 7th decade of life, mainly males, 3 to 2 odds for males to females. We don't really know why that is, but more in males, perhaps lifestyle issues and so on. Most of the time we catch them early, and that's 60 to 70% of the time it's a localized disease, and I think that's the opportunity for cure when it's localized. Regional is when it's spread to the local nodes or regional area. There's still potential for cure in that area, but that's about 20% of patients as well. You want to pipe in and add something, or? No, okay, all right. Okay, you can add anything you want, Dr. Hunt. So he started already. So, and metastatic disease is about 20%, and that's tough for all of us because once it's spread beyond the kidney, metastases means it's spread beyond the kidney to the nodes or to other areas of the body, such as the lung or the liver or the bone. And then it's only about a fifth of patients, but that's where we need to do a lot of good work to try and get cures for those patients as well. And there's good news. Dr. Hutt's going to talk about some new therapies that have up to 10 to 50% cure rate, and so really a lot of reason for hope for metastatic disease as well. I would say that most of the common symptoms are hematuria or blood in the urine, weakness and weight loss. These are all signs of something going on that you should see your doctor about. Many of these kidney cancers we pick up incidentally, especially small masses. You have an ultrasound for some gallbladder pain, you find a mass in the other kidney. We see that all the time, and that's actually a good thing that we can cure these cancers at an earlier stage. So let me go to the next slide here. This is a busy slide, but it talks about the staging for kidney cancer. I think it's important to be educated about how to stage your cancer because it helps look at your treatment as well. So the way we stage the cancer is based upon the size of the tumor, and we base upon the extent of where the cancer has gone. So when it's a T1 lesion, that means it's less than 7 centimeters. That's a first stage cancer. So a 7 centimeter tumor is a T1. T1A is between 0 and 4. T1B is between 4 and 7. T2 is when it's over 7 centimeters. T2B is over 10 centimeters, and those are still localized cancers, but a good size. T3 is when it goes into the veins around the kidney, so that's on the last picture here. This is a picture, if this works here, where the cancer in the kidney has gone into the vein here. This is a T3 cancer, or a third stage cancer. And T4 is when it's gone into the organs around the kidney. So that's the staging based upon the size and the extent of it, and that's very important information after the surgery or treatments as well. Lymph nodes, if it's gone to the area of the regional lymph nodes, that's called N1 or N0 disease. And metastases when it's gone to other organs such as the lung or the liver. And so we use this TNM classification for kidney cancers. If you have any questions during the talk, I'm more than free to just pipe up and ask. So this is the staging. Stage 1, again, is when it's localized just to the cancer. So less than 7 centimeters is stage 1. Stage 2, when it's over 10 centimeters but no signs of any spread. Stage 3 is when it's into the vein, and you see here that goes to the vena cava. We heard some talks about the vena cava there. But if it's into the vena cava, that's a third stage cancer, still curable, as long as there's no signs of any nodes or extend beyond that metastases. Stage 4 is when the kidney sometimes the mass grows beyond the kidney into the organs around it, such as the liver or the spleen or the pancreas. These are the most common pathologies of kidney cancer. So now you look at the extent of where the cancer has gone, whether it's a small mass or whether it's gone beyond the kidney to a big mass or into the nodes. But then you have to look at the cell subtype. That's where we get the pathology. Dr. Bonner slices up the kidney, and we look at the cell type of it. And most of them are what's called clear cell carcinoma. That's the most common type. Then we have papillary type 1, papillary type 2, which is about 15%, and chromophobe. That's about 5%. These are the three or four most common pathologies again, clear cell is what we see most of the time, but these what's called non-clear cell histology is also what we see, papillary type 1, papillary type 2, and chromophobe. Now, for those that have had surgery, there are new recommendations that have come out of our Kidney Cancer Research Network that suggested that anybody who has papillary type 1, type 2, or chromophobe should get genetic testing. We recommend genetic testing because there may be a genetic component for those non-clear cell histologies. If that hasn't been offered by your urologist or your medical oncologist, including myself or Dr. Hutt, just remind us, sometimes we're very busy, we may overlook that, but that's where genetic testing is important. And under the age of 40, we recommend genetic testing. That includes me, but not Dr. Hutt. And for those patients that have bilateral tumors, tumors in both your kidneys, that would be an indication for genetic testing. And we can do that in Hamilton or in regional hospitals to get the genetic testing, and then we get to see a geneticist to go over the results of that. And if there's a mutation, they can give you some advice about how to cancel your family members and so on. Ones at the bottom are benign tumors. Sometimes we do take these out. We can talk a little bit about biopsy, if you information if you have, about whether we should biopsy these or not. But in general, we can look by the appearance of the tumor on the diagnosis side of things that we talked about, and the CAT scan or MRI can give us some idea that it looks like a clear cell or papillary, but it's not as clear as a biopsy, obviously. But if it's an oncocytoma or an angiomyolipoma or an adenoma, those are benign, non-cancerous tumors that never spread. And so sometimes for these small masses, if it is one of those three bottom ones, we're very happy that you don't have to worry about any further follow-up and you're cured because these cancers or these tumors on the bottom never metastasize. So in terms of definitions, we call the top ones cancers. The bottom ones we call tumors, but non-malignant tumors. And the fourth piece of information that we look at is the grading. So we actually look at these cells under the microscope, say, okay, this is a clear cell, this is a papillary, and then we also look at the aggressiveness of the cells. And again, I'm not a pathologist, but you can tell kind of these don't look as angry as these ones on stage 4 here. So I just call it the angriness scale, and if the cells look very angry, that's more of an aggressive grade, grade 4. And these are basically cancers that are quick growing and have more of a tendency to metastasize. And grade 1s are indolent ones. So we can have a big tumor, that's a grade 1 out of 4, and that means that tumor has been slow growing over many, many years, and it hasn't metastasized because it's been so slow growing but getting big. And then sometimes you can have smaller tumors that are grade 4 out of 4, and those are angry tumors that may metastasize that may be a candidate to see Dr. Hutt to discuss other systemic therapy or medical options for treatment as well. So this is what we use, and that's where the pathologist is important to do that. And if there's any question about the pathology, Dr. Hutt and I participate in what's called a multi-case conference where we review these pathologies of our patients with the pathologist in the room and say, is this real, and this looks kind of a bit odd to us, and what is your thought? So we do keep close attention to the pathology as well as the stage and grade. This is these are just some numbers. I don't like to show numbers because everybody's different. I get patients always ask, what are the numbers for me, and we don't know. We're just doctors, and really it depends on so many factors, including the biology. But we can give some estimation. But certainly grade 1 tumors, they're very rarely to metastasize, but grade 4 tumors have a higher chance of metastasize. So let's talk about surgery. Dr. Hutt's going to talk about medical management. I'm not going to get into that at all. But I'm going to talk about surgical innovation. And this is the menu of the brief things I'm going to go over, including keyhole surgery or laparoscopic surgery, partial nephrectomy, where in the past people said all the time, please take out the entire kidney because I got a spare and I don't need to save half the kidney. But now we're moving towards just taking out just a tumor and saving the kidney because the cure rate is exactly the same as taking out the entire kidney. I'll talk a little bit about that, about how we do that. The robot surgery, single port surgery, nanotechnology, and some freezing of tumors. Now, this is the old way of doing things, where we made an incision underneath the rib cage or in the flank, where we go between the ribs. These are tough incisions, they're painful, but sometimes you have no choice but to do these kind of incisions even now. Because if the tumor is very central in the middle of the kidney and we want to try and save the kidney, we have to actually hold the kidney to carve it out and put the kidney back together again. And we're still not at that stage of technology that we can do it robotically if it's really deep inside the kidney. That's still coming, and with St. Joe's we're fundraising for a new state-of-the-art robot We have a Da Vinci robot here, but we're looking at a newer state-of-the-art robot to do these kind of more complex surgeries as we go with time. We'll talk a little bit about that, but this is how we position patients for these laparoscopic surgeries. You're on your side. Some people think they're on their back. We're actually on your side. We tape the patient down because we don't want them to fall off, because that's bad publicity. It's never happened yet. And then this is how it looks taped down. We use some betadine to make sure it's all sterile. We put a warmer on the top, so this is a warmer to make sure that you don't get cold during the surgery. It's called a heat warmer during the surgery. These are the tapes to make sure the patients are secured down. And then we basically go with these keyhole surgery to do the surgery, where we put the camera at the belly button, or just close to the belly button. And with these laparoscopic instruments, we dissect out the kidney. And then if you take out the whole kidney, we use these surgical staplers called the endoGI stapler, where it lays down rows of staples onto the artery or the vein. And these are still good to go to the airport. It's just titanium, and it's not a problem unless you use a lot of them, but we don't usually use a lot of them, just a few rows of staples on the artery and the vein. And then we put it into an EndoCatch bag. This is a surgical sterile bag. To take it out, we don't just pull it out through the incision, because we don't want to break the tumor and spill any cancer. So we enclose it into this bag and squeeze it out through the bag. And this is a description of the bag. These are arrows for those surgeons that get confused. Little arrows that say this is the direction of where to put the kidney. And then we take the kidney out and send it out for pathology. Patients always say, well, how can you take the entire kidney out when it's laparoscopic? And these are the example of the incisions. These are the small incisions here, here, and here. And the kidney's now in that bag. And then we're able to squeeze it out through these small incisions by making sure you pull it out without breaking the bag. It's a very sturdy bag, so it doesn't break at all. And then this is a sample of what we see. It looks like a big mess of fat, but really you have a layer of fat around the kidney, which is normal, called Girota's fascia. I know you guys all just had dinner, but sorry about that. But this is a layer of fat around the kidney called Girota's fascia. And when you do a radical nephrectomy, it's important not to violate that, so there's no cancer spillage. And so patients say, well, how does it look when you look at it? We actually don't look at that. We just leave it like that. We don't want to spill any cancer near the patient at all. We just put it into the pathology bag and send it to the pathologist. Then he opens it up. This is what it looks like. The pathologist measures the kidney, and then they open it up with a scalpel. And this is an example of what's called clear cell carcinoma. This is what it looks like. It's a yellowish tumor on the inside. Papillary is more brownish. This is the normal kidney here, on the bottom here. This is the ureter right here that goes down. Patients ask me how far you take that ureter down. We usually take it halfway down and just clip it. And again, we want to make sure that the margins of this tumor is not violated, because if there's any violation of this margin, then you worry about cancer being left behind, and that could reoccur. So it's important to have that surgery done very carefully with good techniques, and there's no violation of that. And then this is how we close up the incisions and helps with the recovery. I guess at this point we could talk a little bit about patients sometimes asking, well, I'd rather not have surgery because I don't want you to open me up and have oxygen feed the tumor. We hear that all the time. I'm sure many of you have heard that as well. We hear it all the time where patients say that the doctor opened up my family member's abdomen and the cancer was removed, but then they closed up the incision and hi, come on in, good to see you. But that he didn't recover and didn't do well afterwards. I think what happens there is that, I know what happens there, is that when somebody has cancer, your immune system is fighting the cancer. There's some reason why some patients don't get cancer and some patients do get cancer. It may not be genetics, it may be related to your immunity or how strong your immune system is. And for some reason, all of us are exposed to cancer cells every day, but some patients, the cancer cells get a foothold and grow for unknown reasons that we're going to try and figure out through our research. But sometimes with the incision, if you make a big incision, the cancer can proliferate based upon decompensation, because your body's fighting the incision and the cancer, and it can proliferate. So it's not really the oxygen that feeds the cancer, but it's just the decompensation from big incisions or big surgeries that sometimes the immune system can be overwhelmed trying to recover from both. We can talk more about that if people are interested. So then partial nephrectomy, lots of data I'm not going to present today, because I don't know if Dr. Hutt might fall asleep, but there's lots of data showing that partial nephrectomy is the exact same cure rate as radical nephrectomy. This is for tumors at least up to 7 centimeters, but even larger, we can see that. So when patients say, listen, just take the entire kidney out, I don't want to take any chances, I can reassure you, and we should all be, as a community, reassure you that the partial nephrectomy is the exact same cure rate, and then you can save half the kidney or longer kidney to preserve your renal function, which is important if you develop diabetes or high blood pressure to avoid dialysis later on in life. So it's always better to have 1.5 kidneys or 1 3/4 kidney rather than just one. So how do we do the partial nephrectomy? This is a tougher surgery for sure, because you basically have to clamp the artery in the vein, otherwise you can have bleeding when you cut through the kidney. 25% of your blood flow goes at any given time through your kidney. So if you just start cutting through the kidney, what will happen is that it will just keep bleeding, and that's not a good thing. So we have to clamp the artery, clamp the vein with these surgical clamps, and then we cut out these tumors and then put it back together again. So it's much tougher than just taking out the entire kidney, but it's obviously better for our patient. So the orientation for this picture, this is a laparoscopic picture. It doesn't project very well, but this is the tumor back here in the bottom. This is the normal kidney here, and the spleen is up on this side. This is a left-sided kidney here. And then we're using this instrument to cut out the tumor. So we use these we use scissors, and we basically clamp the artery in the vein. The tumor is right here. That's a smaller tumor. And we excise that tumor. This is the normal kidney inside here, and we basically observe to make sure they haven't got into the cancer. We use what's called an intraoperative ultrasound to look at the kidney at the bottom to make sure that our margin is negative, so it's not extending into where we're cutting. And so we use that ultrasound to make sure that the margin isn't violated and no cancer is left behind. So once the cancer is excised, this is the defect, and if we unclamp that, then we just start bleeding quite a bit. So now we have to secure any small blood vessels on this. This is a larger blood vessel here. And so we use technology such as the argon beam coagulator to coagulate this area. If you're a hospital, if you're from another center, they also can use cautery, which also has a very good success rate, but the argon is also very good technology to help secure these small blood vessels. And then we suture it down with these barbed sutures are called what they're called hemalox and laparotized sutures, where basically we use these barbed sutures, and like a sandwich bag, where when you cinch it down, the barb is prevented from opening up again. So there's barbs on the end of this that keeps it closed. And then once we unclamp it, we put the tumor into a bag again and withdraw it, and we analyze it, and that's a good cure and able to preserve the majority of that kidney, and you can see there. So now we have the robot. It's called the Da Vinci robot. There's about, in Ontario, there's about, most of the academic centers have a robot. There's even community robots at Crawford Valley and Humber now, and it's proliferating across Canada. The issue with the robot technology is that it's fantastic technology, but it's not funded by the government. These robots are about $1.5 million to $2 million to purchase, and the technology is a great technology, but it's also very expensive, and the healthcare system is trying to cope with all these extra costs. So through philanthropy, we've been able to acquire these robots at the various academic centers, and it's excellent because when I do suturing with my hand, I can only go this far. If I go all the way around, then I have to flip over. Whereas a robot can do that flipping all the way over with a robotic instrument. So it's good for difficult tumors on the back of the kidney or on the top of the kidney. We're able to get that nuance or that curvature to do it. Can we do it laparoscopically? Absolutely, but this is better for patients because we're able to get the nuances of this. So I do encourage you to donate to your various hospitals, including our hospital, to fund these robots because the technology is good, and the government is still looking at funding the robotic technology as well, and I think that it will be just a matter of time. Because in the U.S. there's a robot in every corner. Not to say that's the right thing to do, but I think the technology is definitely excellent to preserve kidneys and do these partial nephrectomies. This is the range of motion that you can see there. The robots go all the way around, and it's better for more complex tumors to do that because of the advantage of this. We also have this technology called indocyanine green, where you inject this before the surgery. You can see the tumor lights up directly, so you can use this in conjunction with ultrasound as well to make sure you get a negative margin and don't leave any cancer behind. Now, we're also doing what's called single port surgery, where we do the entire surgery just for the belly button. This has been marketed in LA and California as single port surgery. There's billboards for it now. In Canada, we don't need billboards, and in fact, we're not allowed to do billboards, which is a good thing. And you can do the entire surgery through the belly button. And the way this works is we use what's called these bendy instruments, where the instruments, they bend. and you put them all through the belly button, and then you use that technology to the exact same surgery just to the belly button. These are the type of technologies where you put these ports in at the belly button. Really, it's kind of interesting because this is just a big squeegee. It's a big squeegee with some ports inside of it, but it costs a lot of money. And they put that at the belly button, and we basically do the same surgery that way as well. And we also do this at this hospital, single site surgery. It's called single port surgery. You put the squeegee in, and you put the instruments through the squeegee and excise the tumor that way. The surgeon and all his assistants are very close together because we're all trying to get it through that little squeegee thing. So you have to make sure you take a shower that morning. And then we use the bending instruments to do the exact same surgery. This is a picture of the kidney here. And then we excise drop the bowel, put the stapler on the artery and the vein, and then do the same surgery that way. Then we put the bag in through one of the ports. We take it out through that, and you can see these small, just 3 to 4 millimeter incisions, 3 to 4 centimeter incisions to get it out, and it's better for that. I would say that in my experience, a lot of patients ask for their surgery for prostate surgery robotically. A lot of patients appropriately or as they wish do various centers for robotic prostate surgery. I've had very few patients say, I want a robotic kidney surgery as opposed to laparoscopic surgery. Patients really just want their cancer out, and I think that's a very fair thing to say. But if we could do it with good technology, the most important thing is the cancer. The technique is secondary, I think. I know, and I think that's important. But if we can do these surgeries with that technology, then it's good for the patient and recovery. This is the single port robot as well. This is the next evolution of surgery where you do everything to the belly button with the robot. And this is also coming to St. Joe's in the near future with the assistance of our donors for the program. Just to finish up, we're going to talk about freezing and burning tumors. These are another technology where patients who have tumors that are difficult to access robotically or laparoscopically, where you may sacrifice the entire kidney, will offer this burning procedure. What that means is that if you have a tumor that's on the outside of the kidney or near the edge of the kidney, you can burn it up, you can do a robotic partial nephrectomy and save the kidney. But if you have a small tumor in the middle of the kidney, it's really hard to save that kidney because the entire kidney has to come out. It's right smack in the middle where all the blood vessels are. In this case, we may offer you a technology like this, where you can put a probe into the tumor and just burn it off. So we have 3 technologies. We have burning of it, where you call it a radio frequency ablation. We have cryoablation, and we also are bringing in thermoablation, where we use thermal energy as well, or microwave ablation to the tumor as well. And this is what happens here. You put the probe into the tumor, just through the back. It's a day surgery procedure, and then you deploy these tines, and these tines heat up the tumor with heat, or with freezing, or with microwave, and kill the cancer cells in that, and you go on the same day, which is really good. The only thing is the lesion is still there, and we still have to keep a close eye on it for longer than when it's excised. But this is also a very good option for patients who want to save their kidney and try and avoid a radical nephrectomy, which is what all of us try to do. Then you can also freeze it, where you put a little probe in there through either laparoscopically or percutaneously. You get a little ice ball like a snow cone, and you can see the ice ball that basically freezes the tumor off as well. This is what it looks like when we put the ice ball in and the needle tip into the tumor. This is an example of a patient who received this and had some good results. This is the tumor. This is the kidney. It's hard to read these CAT scans, but this is a transection of the patient's body. This is the bowel here. This is the kidney here. This is the spine. This is the back muscle. And in this kidney, you can see the tumor right here. The cryoablation probe went into this probe to freeze it and off. And you can see a year later, this thing is diminished almost to nothing, and a good response to that. Again, there's always going to be a residual scar in there, so we always keep an eye if it doesn't reactivate. But the data would suggest that this is actually an excellent option for patients, almost on par with surgery. We do need longer-term data to confirm that. Just to finish off, I think one of the other things that we're looking at in terms of research is nanotechnology, where you inject these small little robots into the body through an injection, and you can deploy some treatment to the blood cell. And so we're looking at that technology as well, very early stage, but that also looks very promising for these micro robots as well. And I think at some point in the next 10, 15 years, surgeons will be out of a job and we'll be using these micro robots to do that. And I'll be, by then, relaxing on the beach in Florida with Dr. Hutt. No? Not going to happen? Okay. So I think that's all I wanted to say, just a big brief overview, but I'm happy to answer any questions, and if you have anything to ask, I'm happy to answer. Go ahead.
Where does the technology come from? Where is the robotic made? Is it in Canada?
It's made in California. Everything comes from California. So that's where it's made. It's also a bit of a business. There's other technologies that are coming out, but because of the patent on the robot, the other companies are not allowed to develop anything further based upon it. There's actually a robotic company in Ancaster doing some great work with medical robots, but they're still early stages.
Just one quick question. You mentioned
Cold
cryoablation.
Blue Adult, by the gift shop, Tower Level 1. Cold Blue Adult, by the gift shop, Tower Level 1. Cold Blue Adult, by the gift shop, Tower Level 1.
Go ahead.
Just mentioned cryoablation and radioablation. You also mentioned a new technique that's coming. Is it microwave?
Microwave ablation, yes. This is actually taken up in the US, but we're limited by, again, funding in Canada for this. But this is a microwave therapy. We can actually, the RFA, it takes about an hour and a half to do that because you have to just cycle the RFA. The microwave ablation actually takes about 15 minutes. And really big, better results on some of these other technologies.
That's good to know, but are the parameters the same if a tumor placement is difficult for cryo or radio? Would the same follow suit for the microwave?
It would, yeah, because basically the worry is that if it's near a blood, when you do surgery, you can move the blood vessel out of the way or protect the blood vessel when you do surgery if the tumor is nearby it. But when you use these other technologies, if the probe goes near a blood vessel, it's uncontrolled if it's near that. So we're very selective about that because you don't want to burn a hole in an artery or burn a hole in a vein. So if it's very close to any blood vessels, we don't offer those technologies.
Okay, thank you.
I'm curious, when a patient has a nephrectomy and tumors removed, what determines if they need further oncology care?
That's an excellent question. So you're talking about what's called adjuvant therapy or therapy after localized cancer. So the question was, I'm not sure if you want me to repeat it, but the question is there any role for any therapy after surgery? And that goes back to the original slide, briefly over there, and it goes to the risk of reoccurrence. And basically the answer is we don't know yet. There's clinical trials for that space. There was a number of trials looking at tyrosine kinase inhibitors after therapy, and it showed that sunitinib may have what's called a disease-free survival, but not an overall survival. So based upon that, we don't think that that's the best option for patients. But there was 4 adjuvant immuno-oncology trials that are going to read out in 2022. And so we'll see what those show, because that may be promising for patients that after you have a big 15-centimeter tumor removed, you know the risk of reoccurrence may be high, but perhaps offering an adjuvant drug would decrease the risk of the cancer coming back. And again, I think as urologists, we need to do a little bit of a better job to educate patients about the risk for recurrence. And I'll go through that right now. Just briefly, is let's use this one here, I guess. So if you have a stage 1 cancer less than 7 centimeters, your cure rate for that surgery is about 90-95%. So it's very high cure rate if you have a tumor less than 7 centimeters. If you have a tumor that's over 7 centimeters and over 10 centimeters, T2B, the risk of reoccurrence is about 20-30%. So that's still very good odds for that, but the T3 is where we really worry about patients when the tumor is into the vein. Then we can do a great surgery, and the CAT scan after the surgery is negative, showing that there's no cancer. But we know the risk of that cancer coming back is actually about 50-50. So because there's a 50% chance of coming back if you have a vein thrombus, then we would like to offer a drug afterwards to decrease the risk of that cancer coming back. That's called, again, adjuvant therapy. Right now, there's no approved adjuvant therapy in Canada, but hopefully those clinical trials will be positive and helpful for patients in 2022. So we'll be on top of that. And so that will be an adjuvant nivolumab, adjuvant immuno-oncology drug, which may be an option for patients. Dr. Hart, you want to add anything to that? I can tell you kind of...
I'll mention right.
Oh, okay, all right.
Dr. King.
Hey, Mr. Barton. A friend of those, Steve Barton, one of the famous kidney cancer patients that went to see Guns N' Roses with me. I took him to Guns N' Roses about 3 years ago. We had a great time. It's on Facebook.
That's all I want to say. Carry on. I have a question about the cryo freezing. Will that work on metastatic tumors?
That's a great question, Steve. I knew you were going with this. So patients have, and you can back up Sebastian if you want as well. Patients have a mass in their kidney, and they also get a spot in their lung or a spot in their liver. We don't just we can have the option of going on drug therapy, but actually there's been some good data showing that you can resect or treat the kidney cancer as well as the lung spot and cure a patient, right? So or high chance of cure for that patient. So it's called metastatectomy. When you have a metastases and you do a metastatectomy and remove that spot, that's really the goal. And there's a number of ways to remove that spot. You can do a surgical nephrectomy or radiotherapy to a surgical nephrectomy or radiotherapy to a kidney tumor, or you can do SBRT or radiotherapy to a tumor in the lung, or even RFA, a lung tumor, or RFA, a liver tumor. So I encourage for you to ask your oncologist about that, or your urologist about that, is that, well, there's a questionable spot here and there, and that can be treated as well rather than just going to drug therapy. You might need drug therapy anyway afterwards, but trying to do a metastatectomy with radiation, RFA, cryoablation is really the way to go.
Thank you.
Great question, Steve. I do. Next, Guns N' Roses is coming back. We gotta go. Sorry, in the back.
Yes, sorry, I have a question. If somebody is diagnosed with stage 2 and has their kidney removed, how long after, if they're diagnosed, I guess my question is if they have metastatic disease only a couple of years later and no treatment in between, is that likely to happen, or does that mean that it wasn't diagnosed properly or staged properly with something?
So if somebody has stage 2 cancer,
Yeah, and it's removed.
so that would be, would be a 7-centimeter tumor, I guess, or over, and then develop metastases afterwards. So that's where the numbers come from. The cure rate is about 80%, but there's a 20% chance of it coming back. So that means 2 out of every 10 patients, the cancer may come back within 5 years. That doesn't mean the surgery wasn't done properly or not staged properly. It's just a problem with cancer and the biology of the cancer, that there's 20% of patients, or 2 out of 10, where the cancer will come back in 5 years.
Is there a percentage that if you had it in one kidney, you might get it in the other kidney?
Yeah, the percentage is low, less than 5%. Have a seat. Oh, Dr. Slavin, this is Dr. Slavin. We call him a cannabis expert. No? Palliative care doctor. I know everybody's here not really to see me or Dr. Hutt, but to see the cannabis. And she has samples afterwards, so that's good. It's not that common actually. The most common spot for kidney cancer to reoccur is actually the lung, not the other kidney. If you have 2 what's called synchronous tumors, where the tumors are found at the same time, that's where we worry about a genetic component. We don't know what causes cancer, but it may be genetics, it may be environmental. Many times you never know what causes these cancers. It's just bad luck. But certainly, if you have, if you have more than one cancer, if you have cancers in both kidneys under the age of 40, family history of cancer, we require genetic testing because that may be a genetic component. We shouldn't smoke. We shouldn't drink too much. Maybe, well, I can. But and we should exercise. Right? We should keep exercising regularly. There's lots of data showing that would prevent preventative for cancer. With that, maybe we'll get Dr. Hutt to come on up. I'm going to introduce him. Come on up. So Dr. Hutt, a great colleague of mine for the last almost 20 years now. He trained at the University of Ottawa in 1996, internal medicine at the University of Western Ontario, and then did his training at Medical Oncology at Western University, and now is involved in clinical research. He's the chair of the research program at the German Cancer Center for phase 1 trials. He's involved nationally in many prostate cancer trials and kidney cancer trials, and overall just a great guy and a great positive. So thanks for coming, Sebastian. We'll look forward to your talk and we'll load it up for you. And you may notice he has a mustache. You want to explain why you have a mustache here?
Because I look good. You look good with a mustache. It's Movember, so if you have some extra dimes, it's for a good cause. I think Movember, as you know, is for men's health issues. I think I'm a medical oncologist. So I'm a drug guy, and I treat cancer with various medications and drugs, but especially patients who have different types of genitourinary cancers, prostate cancer being one of them, testicular cancer being another one of them. And I would say that probably most importantly what Movember does, and that's not really just, the talk's not to be a plug for Movember, but men's health issues have really come up to the forefront as to what Movember does and raises money for, and God knows that men are not very good at talking about their feelings and handling mental health very well. So we need some help there. We're going to switch gears big time though. We're going to talk about the current treatment of advanced renal cell carcinoma. So what Anil really focused on, and thank you Anil for being nice, that's not every day that Anil's nice to me. So I think it's nice to me so that I could be nice back. But what he focused on was the surgical management, and with that, it is often when things are localized, or sometimes when things have spread, so when they become metastatic disease, but we think that it's a good idea to still get rid of the primary area of the cancer, what we call a cytoreductive nephrectomy. However, if the cancer either comes back or has already metastasized, has already spread, then surgery cannot mop out everything. Radiation cannot take care of everything. You can't fully radiate someone, but that's called Chernobyl, and you don't do very well. So you have to look at something that's more systemic and a bit more safe than that. Because I use a lot of drugs, because I do a lot of clinical research, I have disclosures. Most of us that do this type of work have a number of disclosures, and this is what you should be seeing actually from anybody that does talks about various medications. I do a lot of research and therefore has some funding to the institution. I work at the Jurvinsky Cancer Center. And I also talk to various companies that have these drugs as to how can we get our patients to use these medications, who should get it, who should not, how does it get funded, and that sort of thing. So take whatever I say with that grain of salt. I think I talk to every single company that does drugs in kidney cancer spheres, so that hopefully that if you talk to everybody, then you don't particularly prefer one versus the other. We're going to start here with what is cancer, because we kind of talk about, we jump ahead a fair bit, and sometimes we don't even go back to what is cancer, and when I ask a lot of my patients, sometimes they don't really know, because cancer is this big word. A lot of people means it's one disease, it's one thing. But it's a lot more complex than that. It really is a single cell that decided to go a little wacko on us. And it's acquired some characteristics that makes it do two things. It divides when it's not supposed to divide. So if you put a cell, a skin cell, any cell, in a petri dish, in a dish, it will divide and then it'll touch something else and it'll stop dividing. What cancer cells do is that they won't stop when they touch something else. They'll just keep on growing, and they'll form a ball. And that ball is just, it will never end. That's one thing. The other thing is, any cells have a lifespan. They will divide. So cells need to divide because we slough our skin, we just have this mechanism of renewal. And our cells have a lifespan, and they can only do that so many times. And after they've done it, they have this signal, okay, you're done. It's called apoptosis, or programmed cell death. Cancer cells lose that. How do they lose that? And how do they grow when they're not supposed to? It's because they develop these mutations, so these genetic changes. And Anil spoke about the sort of things that predisposes us to cancer. Well, it could be you're born with it. That's only about 5 to 8% of men and women who present with cancer. That is a genetic kind of predisposition. I think we all have more or less predisposition without having a family history, a familial type of cancer. But also it's these other things in terms of having too much weight, smoking, drinking too much. A lot of the time we don't really know. And it's also bad luck. So our cells, when they regenerate themselves, they have to copy their whole, it's basically a computer that does the disk kind of copying. All of the genetic information has to be recopied. And there's errors sometimes that gets made. And these errors usually get picked up. Sometimes they don't. And if they don't, and they happen to be at an important spot then they can actually engender a problem. And really they behave, like I say, in this manner because, you know, where they have these changes is in a specific gene, an important gene that is called a cancer gene. So really all cancers are genetic diseases, although most cancers are not caused by a genetic predisposition, like von Hippel-Lindau or other types of genetic problems that you might have read about or even have in the room. So kidney cancer is really not just one disease. Any cancer is just not one disease. In 2004, the World Health Organization had actually 50 different types of kidney cancer. Some of you may have read or may have sarcomatoid renal cell carcinoma. That's really just a variant of all of these subtypes. But really, I think as Anil mentioned, and I won't take much more than that, most of the kidney cancers we see are clear cell kidney cancers. And as a result, unfortunately, for those who do not have clear cell renal cell cancer, most of the therapies that we have in patients who have cancer that has spread, that have metastatic disease, are for clear cell renal cell cancer. We do have a clinical trial. I'm not talking about it at the end, so I want to plug it because Dr. Kapoor is involved in it. It's called REC3. So for men and women who have a kidney cancer that is not a clear cell type and have the cancer that has spread outside of where it is, we are looking at newer types of medications to see if it works better than what we currently have. So how is kidney cancer treated? Anil showed some interesting, yummy pictures of surgery. Good thing I didn't have dinner. Sometimes observation may be best. And actually there are some people in this room that know very well that we can go 3-4 years sometimes, and your cancer grows very slowly. The cancer spread outside of where it started, but it grows very slowly. And because of that, we can avoid having drug treatments that have side effects and only work for a certain amount of time. And then when you actually really need them, then you can actually use them. Radiation therapy, I'm not a radiation oncologist, I'm not going to talk about that much, but it's really just a way of burning, in a way, of the cancer in a very precise fashion. Radiation, a lot of people remember cobalt, when they just basically tore a hole in people because we didn't really know how to use radiation. Nowadays we have stereotactic body radiation, or SBRT, or a gamma knife, where you have a radiation machine that goes in a 360 around a person and is able to deliver really, really precisely at the millimeter or micromillimeter the radiation so that the normal tissues can get spared, so you can get really big doses. So it used to be thought, if you have kidney cancer, radiation doesn't work. Old type radiation doesn't work. New type radiation can work quite well. And then the last part is really what I do, and it's chemotherapy. Chemotherapy just means drug treatment. Chemotherapy, like intravenous stuff that you lose your hair, nausea and vomiting, that sort of thing, firstly doesn't work very well for kidney cancer, so it's extremely rare that I will use something like this. So when you think about chemotherapy, just think about, it really just means drug treatment, and there's a whole ton of them. There's some of them that are oral, some of them that are intravenous, and they all do slightly different things. And we can actually divide them more, though, into targeted agents or vascular agents and immunotherapy. And I'll spend the rest of the talk really talking about that. And why are we doing this? Well, to do a number of things. One, at the bottom, which is really the most important, but unfortunately the less frequent, is to cure. So in my business, cure is not a word that I use often, because cure means that for sure it's not going to come back. We often talk about remission. Are you in complete remission or in partial remission where the cancer is shrunk down and it's staying put? And then obviously it can be a lasting complete remission, but hopefully we mean that it's never going to come back. But it's very difficult to know because we don't have a way of looking into the future. If you don't cure, then we want to make people live longer, obviously better as well, but also longer, and that's overall survival. And then you can actually then prolong interval without tumor growth, so you can keep the cancer from growing, keeping it stable, and that's progression-free survival that we call that in our papers. Means that you're free of progression. And one of the easier way or first ways that we have to tell us or give us an idea of the cancer is doing, or the treatment is doing something to cancer, is if there is improved tumor shrinkage. So is the cancer actually shrinking? And that's called a response rate. Really, I started around 2004, a little bit before, and we had nothing. We had a drug called interferon and a drug called interleukin-2 that you can sometimes get into the US in high dose. And that was a particularly difficult treatment. It didn't work very well, and it made people feel like they had a really bad cold all the time, and it made them depressed. And for various reasons, there was a lot of research happening, finding how cancer cells worked and how specifically kidney cancer cells ticked, so that between 2000 and 2010, we had 4 new drugs, and then in the last sort of 10 years, we're up to 12 different treatments or combinations of treatment for kidney cancer. Same thing with regards to funded line of therapy. The numbers are very different here, but in the last sort of 5 years or so, we're up to 3 different lines of therapy, where until 2004, we only had that badly, sort of the bad drug in terms of interferon. So, what type of drugs, or what type of treatments do we use for people who have advanced cancer? There are 2 main groups. One is anti-angiogenic or targeted therapies, and those, they inhibit or block these mechanisms that make blood vessels. So angiogenesis, angio like angiogram, blood vessels, genesis like the Bible. Manila, you wouldn't know. But the Bible is just the formation of, and I do have to do some quotes from time to time. And for biological reasons, kidney cancer is the poster child for the formation of these new blood vessels. Most kidney cancers are very dependent on these blood vessels, and that's why sometimes you'll hear, especially in the community, the surgeon or the pathologist or the internist or the oncologist say, I don't really want to do a biopsy because I'm too afraid it's going to bleed too much. Or sometimes your surgeon may say, well, we need to stop the blood vessels or block the blood vessels before we do the surgery because we're too concerned about having bleeding. And that's because they really make a lot of blood vessels through that phenomenon of angiogenesis. And they use that to go elsewhere. They use that to feed themselves. So if we can block that, and we can block that by these 6 drugs that we have here, they're called the IB drugs. So sunitinib, pazopanib, axitinib, cabozantinib, lenvatinib, sorafenib. And if you can say those 6 times, real fast 5 times, these 6 drugs real fast 5 times, you can drink all you want, and then you get to a ride program, and you can say that, and you're going to be okay. Don't do that, though. I know it's being filmed, so I do not advocate drinking and driving. Yeah. In Newfoundland, it's okay. That was also a joke, Newfoundland.
Dr. Hart, we have a question coming in from Newfoundland now.
Do we really?
We do.
And that, a number of years ago, sort of in that 2005 range, when I was really starting my career, there was these trials that looked at interferon compared to sunitinib or pazopanib. And they really showed unequivocally that people who received these drugs, their cancer weren't cured, but they lived so much longer. And, Dr. Kapoor showed a little bit what your odds of being alive at a certain amount of time. It was my kidney cancer clinics when I started in 2004 were tiny, because most patients either didn't want treatment or didn't do very well on treatment, unfortunately passed away quickly. Now there are people that, we're celebrating decades, and they've lived with their metastatic disease, and we do not used to see that, and it's because we're able to really target these blood vessels a lot better. And then we found drugs that actually, once the cancers learn around it and find ways of resistance, we can actually then use these medications because they can counteract that. So cabozantinib is an example of that. we always knew that immunotherapy was a way of killing kidney cancer cells, and that stemmed from if sometimes patients who had bad infections, afterwards their cancer that had spread actually shrunk. Or people that had their kidney cancer removed and they had cancer elsewhere, they had some spontaneous regressions. It does not happen very often, but it did happen. So we knew that the immune system played a role and really wanted to kill the cancer cells, but unfortunately often was not able to. And even if you boosted it with interferons, you were not able to do that. So over the last really 5-6 years, we've found out ways that we can actually stop the break that the cancer cells develop that prevent them from attacking the cancer cells and getting rid of them for us. And those are what the 4 drugs at the bottom are. Those are the MAB drugs. So nivolumab, ipilimumab, pembrolizumab, avelumab. There's also atezolizumab, but that one is not going to be a part of our drug armamentarium in Canada. So go back to those 2. First, what is angiogenesis? Well, angiogenesis is the formation of new blood vessels for pre-existing vessels. I told you about that. It is a normal mechanism. If you cut yourself, you actually need to have these new blood vessels that get created so that you can heal and that you can scar up. However, it's when the balance goes awry that things are a problem. So everything is a balance, and you have on the green side the angiogenesis inhibitors, so they're the blockers of the blood vessels, and then you have the activators that make angiogenesis happen. And then when that balance is in control is where you just keep on making blood vessels, and then if you keep on making blood vessels, then you keep feeding the tumors and you keep making these roadmaps for the tumors to go elsewhere. And that's really what is the hallmark of a lot of kidney cancers is you've got this protein called VEGF, which means vascular endothelial growth factor. And vascular endothelial growth factor, the person at the top is Jutta Falkman, who should have had the Nobel Prize, but unfortunately died in 2008 and never got the Nobel Prize. He got laughed at when he told people that blood vessels are really important, and there's this thing called VEGF, and if you actually block it, you're going to shrink the tumor down. The guy at the bottom is actually very much still alive. His name is Bob Kerbel, and he also has been a pioneer of angiogenesis, and he's actually a PhD at Sunnybrook, and I think still kind of working. I think he's still quite active. So because of these 2 people, we've had a number of drugs that have really changed how we treat cancer, kidney cancer specifically. So immunotherapy is the other big class of weapons that we have. At the bottom is James Allison. Jim Allison is, well, I think he would say his main career is to be a jazz harmonica player, or blues harmonica player. He actually played with Willie Nelson and a bunch of people. A bit of a hippie, but a brilliant man who discovered this thing up top, which is called CTLA4. And CTLA4 is a mechanism by which the cell, sort of the immune cell, specifically the T cell and the dendritic cell, has this mechanism of check. We call it checkpoint. So again, just like angiogenesis is this balance of yin and yang, of pro and con, the immune system is the same thing. So you want your immune system to attack things that are not supposed to be there, but you don't want it to go and attack everything. So, because if it does, then well, it's called autoimmune disorders, and that is a disease, and that is a problem. The person on the right is Tasuku Honjo, and he discovered PD-1, which is another one of those checkpoints. So Dr. Allison really discovered that checkpoint. It happens at the level of the lymph node, so it happens a little bit more centrally. And you need to stop that checkpoint, to block that checkpoint, to get the immune system revved up. Once it's revved up, you actually then need the immune system at the level of the cancer cell itself to be able to attack the cancer cell. And that's what PD-1 does, and if you block it, that's what you stop, that's what you allow it to do. So that's really, I think, that in a nutshell. I'm not going to go over that slide anymore, just to say that if you see on your left side, there are a number of drugs that affect PD-1, or that block that PD-1 so that it stops that checkpoint, so it allows the activated immune cell at the level of the tumor microenvironment to kill the cancer cells. But before that, you need to prime that T cell, and that often happens at the lymph node, and it's with a drug called ipilimumab, which is an anti-CTLA-4 drug. So some patients will respond to the immune therapies, some patients will respond to the vascular therapies, some people will respond to both. How do we predict who responds to what? It would be nice if we actually could have a test or a bucket, or a kind of a wand for those Star Trek things that would tell us which thank you, the tricorder, which drug would work best in which patient. We're getting a little bit closer to this, but we don't have anything yet. And this slide, I thank Christian Komensberger from the BCCA for giving me that. And unfortunately, we don't have these yet. There are some research tools that tell us after the fact, oh, this person would have done better with this drug or that drug or a combination of both. But we're not there yet, and that's part of what we're working on. That's part of, I think, a lot of you, if you have had kidney cancer and your information is part of a database that Emil mentioned in the terms of the kidney cancer CKCI, information, CKIS. I need to drink more. Kidney Cancer Information System. Then I'll go overtime big time. And part of actually that information that we have is to see, okay, people have gotten this drug, that drug, they've responded well, they haven't responded well, and we can actually go back at what kinds of tumors people had to try to then inform the rest of the world, and we use information from other people around the world to all help us out trying to find the best treatment for the best for the right person. These are the drugs that have been approved since 2006. So interleukin-2 was approved in 2006, used very seldomly, and only usually in the US, sometimes in Montreal. The cost was about $250,000 US to go, and about 3 out of 100 people had a good response. So it wasn't something that we use very often, and extremely toxic, so not for everybody. And then all these oral, what we call TKIs, or tyrosine kinase inhibitors, all these IBs started to arrive, starting in 2006, between 2006 and 2012, and then lenvatinib and cabozantinib are the newer kids on the block, and they're kind of these newer generations who try to go around some of these mechanisms of resistance that we've developed with these first IBs. mTOR inhibitors are used a little bit less often now, and the newer ones really are nivolumab and ipilimumab in terms of the ones that are approved so far. So what do we have approved and used or funded in terms of kidney cancer treatments in Canada? Is for first-line use. So if you've never had a systemic therapy, if you've never had a drug for your cancer that is spread outside of the kidney, then there are the options of sunitinib or pazopanib, and that's been the only options until about a year ago. And if you have certain risk factors, we call that the Heng risk factor. Danny Heng is a worldwide, world-renowned medical oncologist in Calgary who's developed these number of predictors that tells us how well men and women are likely to do, and depending on the number of predictors, then they may have a cancer that behaves better with immune therapies, or if you have none of these risk factors, you may actually do better with a drug like sunitinib or blood vessel medications. So ipilimumab and nivolumab is those two immune therapies together that have been approved for first line if you have intermediate or poor risk disease. After these medications don't work anymore, then we have other drugs. Most of those are, well, actually one of them is a NIB, axitinib. Everolimus is we'll call an mTOR inhibitor, which is a different class of medication I'm not going to get into. And then the immunotherapy, nivolumab, can also be used if you didn't use it already. In Ontario, and really in the rest of Canada, if you have not used nivolumab and you've used axitinib, let's say, second, then you could receive nivolumab for some reason that I don't understand. If nivolumab is used second, unfortunately, the governments will not allow us to use another medication afterwards, at least as of today. We're hoping that it's going to be changing. Certainly, you letting your MPP know that is not appropriate is not a bad way of trying to move things along a little bit better. And how do we actually know which medications to give around the country? Well, we talk to one another. We actually get together and we develop these consensus papers that we review all the evidence. We say, okay, what should be a good treatment and what should be offered to our patients. And Dr. Kapoor and I were involved just recently in the 2009 update of this, and it's a bit jargony, but if you're interested, it really gives the sort of up-to-date summary of where we think what we think patients should be treated with, and if they have advanced cancer. So a little bit more in detail for the last few minutes in terms of those combinations. The one new drug combination that is funding, as I mentioned, is ipilimumab or with nivolumab. We call that ipi-nivo. It's a combination of two immunotherapy drugs. I told you how they work. Kind of one of them is the primer. The other one is just to keep things going once you're primed. And they're given as an infusion. The two of them every 3 weeks, up to 4 times. And after that, you continue with maintenance nivolumab, usually either every 2 or every 4 weeks. And it's given as an outpatient, and you have to keep an eye on potential side effects, certainly, especially when you're on the 2-drug regimen, because the primer is a bit less specific. It revs your immune system in a more generic way, and so the immune-related side effects can be worse. When it was compared to sunitinib, it showed that it was superior in terms of response rate, so in tumor shrinkage. It was better in terms of progression-free survival, and it was better in terms of overall survival. And something that we didn't see before is that the tumor seemed to disappear completely in about 1 in 10 person. If you actually have that sarcomatoid type of cancer that I mentioned briefly about, it's about 1 in 5 person. So about 20% of men and women would have their cancer go away. We don't know if it's a forever thing yet. Those treatments are too new. We are hopeful, but that is kind of where we're at with these treatments right now. They're usually well tolerated, but if you're going to have a side effect, it's because your immune system is just revved up, and sometimes we need to tell it to back off. How do you do that? You give steroids like prednisone or dexamethasone, and about 1/3 of patients will need that. That is one method, is to go all in with immunotherapy. The other way is to edge your bets and to have a little bit of both. So immunotherapy plus blood vessel therapy, so a nib and a mab. And so axitinib is that nib, and it's given as a pill with pembrolizumab, which is the mab, and as an infusion every 3 weeks. And the axitinib is given continuously, usually twice a year. And then the pembrolizumab is given for a maximum of 2 years, because that's what the clinical trial showed. It's again as an outpatient. What did it show? Well, there was a trial again that compared it to sunitinib, and it showed that it was superior in terms of tumor shrinkage rate or response rate, in terms of progression-free survival, in terms of how long people live. And about 6% of people had their cancer go away completely. Does that mean that the other one is better? Not necessarily, because at the beginning, when it was first reported, the 2 immune therapies, the likelihood of the cancer going away completely was about 8%, and now it's 11%. So the longer you follow things along, the more you can have a response. So we may actually see some improvements as time goes on. And I'm not going to talk about avelumab and axitinib because there's a question mark here, and that's really because it's not Health Canada approved yet. but it's very much the same principle. And how do we decide? It is a difficult question. So there are some types of cancers, like sarcomatoid, where I think that immunotherapy is really the hands-on best one. In the good risk, where it used to be just sunitinib, well, it could still, or pazopanib, it could still be sunitinib or pazopanib, or it could now be the combination of axitinib plus the one of the mAbs. In intermediate to poor risk disease, there's no head-to-head comparison, so it depends. Do you want to go all in, or do you want to hedge your bets? Sometimes if the cancer is not going to go completely away, we need to also be aware of what else we can do after, what other lines of treatments do we have, so how do we sequence the patients? And how do we sequence the patients, or what do we have after? Cabozantinib is an important part of that. It's one of those NIBs, and it's an oral drug, and it does have a certain side effects, but it showed an overall survival compared to some of the older drugs that we have, and it's usually fairly well tolerated, but it does have some significant toxicities, and I'm sure some people around the room could tell you that. So what are some of those side effects? The main ones of the NIB drugs, more tiredness, some increase in their blood pressure because it affects blood vessels, so it just makes sense. They can have sore mouth, so we call stomatitis or mucositis. Not usually sores in the mouth, just sore mouth, and really dry mouth, like I do right now. They can have some indigestion, diarrhea can be common and problematic. They can have skin rash, and they can have some issues with their hands and their feet, especially around the time where there's calluses. And so to have really good hand care and foot care is very important, and probably to get a pedicure before you start treatment is not a bad idea. What about those NIBs? It's how do you manage them? So sometimes it means that you're just symptomatic, sleep more, or you take less caffeine, things like that. Dose adjustments, treatment breaks, a combination of above. But what you really try to do, and what we've actually shown, and Canada has been at the forefront of that, is I tell my patients, if you don't have side effects, I feel like it's pretty sadistic when I say that. If you don't have any side effects, it's too good to be true, because the drug is not likely to work if you don't have any biological reason that tells you that it's working. So you usually need to push the dose as high as possible for people to have some side effects, but that are quite manageable. And then you give some breaks in order to achieve that higher dose. What about the immunotherapies? What about the mAbs? Well, it's really about overshooting the immune system. And about 20% will have some, and about 20-25% of patients, especially when they receive both, will need a bit of steroids. The main ones are colitis, which is inflammation of the bowel, and that's probably one of the ones that we want people to know about and tell us about ASAP, because it's not the diarrhea that you want to take Imodium for, it's the diarrhea that you need to have steroids, because if you have Crohn's disease, you definitely don't want to slow things down. And that's really what we cause, is a acute Crohn's disease that we can back off with steroids. Sometimes it can be hepatitis or dermatitis, any itis really. And then that's really not to scare people, but any organ, any skin tissue, or any tissue, including skin, can be fair game here. Yes? Yeah?
On the slide just before this
Well,
one.
one second. Hold on. One second.
Sorry. I can talk about it. On the previous slide, I was just curious, type 1 diabetes is listed as one of the side effects.
It is not. It is because it's not a common one. But if you actually look here, it's here. And it's probably, you're too far. But pancreas type 1 diabetes and pancreatitis is listed there, is extremely common, thankfully. But that is a possibility.
For a patient that's on that drug, how do you know that that is a side effect? I mean, what would be the symptoms?
So if you have a concern about diabetes, certainly it's somebody tells me all of a sudden I'm drinking more, I'm always thirsty, losing weight. Losing weight is a difficult one because there's a lot of reasons for that. But mostly it's because you're feeling thirsty. And then most of us, I think actually all of us, when we see patients, we do blood work, and part of that blood work is on a fairly regular basis to do a blood glucose, and that would cinch it easily. And then you kind of find out whether or not it's type 1 or type 2. That's usually the endocrinologist that we involve for that.
Would you recommend that a patient that is on immunotherapy, if they have to go to emergency, that they call their oncologist or try to contact their oncologist to let them know that they're going into for attention?
If at all possible, yes. Steve?
Hi. One of the last drugs you discussed a moment ago, you said that you would gauge the efficacy of the drug by the side effects. But my experience with some of the drugs that you've given me, for example, I'm on cabozantinib right now, and I'm pretty sure it says if you don't have side effects, the drug could still be working. So is there a pattern to them where some gauge by the side effects, some don't?
Yeah, you get doing good questions tonight. The easy answer is most of the work has been done with sunitinib. Less with the other drugs, but actually to a certain degree, axitinib and even cabozantinib. If you have no side effects, it does not mean that you're not going to respond, but it's less likely.
Gotcha.
If you have side effects, it does not mean you're going to respond, but it's more likely. At least you're stacking the deck towards it working. So, and that's the main thing. And there are some people who just for some reason have no side effects, and they're on higher doses than normal, and you have side effects, so you're good there.
Okay.
But I don't want to give you any more side effects than that. Oh yes.
Just curious about the relevancy of eye side effects. I've not really heard much about eye side effects before.
Again, they are uncommon. They can happen with any drug. They can actually happen with my mother. I wish that was not true. It is my mother. I'm French Canadian, so I'm
She's calling you to tell you that we ran out of time.
Yeah. So eye side effects with the immunotherapy, again, you can have uveitis, you can have inflammation of the eyes, and that would require usually topical steroids, so eye drops. So if somebody all of a sudden tells me that they have painful eyes and they're on immunotherapy, I would make sure that they go see an eye doctor. Most doctors outside of ophthalmologists or optometrists are horrible at looking in people's eyes or dealing with eyes. Yeah, well, that's the thing. Well, the thing is they would treat with steroids, which is what you need to do. Dermatologists and ophthalmologists, after steroids and a bit of antibiotics, they're kind of done, right? There's not a whole lot of other treatments they do. But that is a good treatment there. So,
Just a real,
yeah.
if you're on a clinical trial or on the MIBs and the knobs, and you're not really having many side effects, but you are showing some improvements, cascades and things like that.
Yeah.
Is it recommended that you bump it up until you
No.
you start to go
No.
down the hill?
So, and that's the beauty of imaging. So if you're tolerating it very well, and your scan is showing you're going the right way, then you keep on going. What we do sometimes, if it's possible, and that's usually with the nibs. If things don't work quite as well, is then we actually start to raise the drug. The immunotherapy, actually most people do not have side effects, and there's no correlation. So the too good to be true with regards to side effects, it's really the oral drug that look after blood vessels, not the immunotherapy ones. We don't want to push to side effects with the immunotherapy if at all possible. So last few words about clinical trials is that they're vitally important, and they're a way that all these drugs or these treatments are now part of standard of care for us to discuss with our patients. And just like any treatment, they may or may not benefit. And certainly the main message is talk to your doctor about that. Sometimes they may not think about it right away or front of mind, but it's important to talk about them. And a couple of plugs is coming up is in somebody that presents with cancer that has spread, and we're going to start on ipilimumab and nivolumab. Sometimes Dr. Kapoor will take the kidney out, sometimes he won't. And in the situations that he won't, for various reasons, we think that if we radiate this, we may actually make the immune therapy work better. And there's a clinical trial that Dr. Kapoor is the surgical lead, and myself with a few others at the cancer center are leading, that's going to look at that. So half the people are going to have radiation to their kidney along with the immunotherapy, and the other one are going to have the immunotherapy without the radiation, because that's not something we would do normally. And then we'll see at the end of the day if people do better. And certainly if you've done well, it doesn't mean that you can't have your kidney removed sort of after a year or so. And that's something that we always involve, we'd always talk about with our surgeons, especially Dr. Kapoor. And Rec 4, because I told Anil that I would plug this, there was a question about adjuvant therapy. So who would be a candidate, or who would we think about in terms of adding treatments after? And like Anil said, unfortunately, there's no standard treatment right now. No treatment is really shown to increase the likelihood of cure in people who are at risk of the cancer coming back, but we're hoping that immunotherapy will do that. And we're hoping that if we start immunotherapy even before the kidney cancer gets removed, so that we can actually get the immune system to recognize those bad cells and then get that immune system going afterwards, may actually be a better way of doing that. And that is what the trial is going to be starting within the next week or so. So Dr. Kapoor is the Canadian principal investigator surgically for this. And you'll need a biopsy at baseline to get a diagnosis. And then people will either have the immunotherapy, or we'll go directly to, and then we'll have the surgery, or we'll go directly to surgery. There is no placebo. Some of these trials have sham infusions. There is none of that here. And so, really to summarize, there's a much more medications that are available. There's actually a lot more clinical trials that we have that look at really new types of treatments called phase 1 trials that we have. I head up the program in Hamilton. That may be an option if things don't work anymore, or if we've run out of options that are looking promising. So those are all something that you should talk about with your oncologist. All treatments have side effects. Not all treatments make the cancer go away. Not all treatments even make the cancer better, but more and more do. And certainly that's not for us to discuss, but the financial toxicity is becoming a big problem. Even in the US, they're talking about it, and hopefully that will be something that'll get worked out in the next years. So hopefully we'll change oncology to ophcology very soon, and I thank you.
That was excellent. That was a great talk. A lot of great information. We'll take some questions. Any questions before the break?
The immune therapy, nivolumab and
Ipilimumab.
that one,
Ipi.
are they always given together, or?
No. Good observation and good question. So the way that, the only time that Ipi gets given with Nivo is in people who've never had treatment before. There have been trials looking at Nivo by itself in men and women who've had other sorts of treatments before, like some of the NIVs, and then go on to immunotherapy. That was only with nivolumab. So the only way right now that anywhere in the world, because of the evidence, is to get immunotherapy after you've had a drug treatment is with nivolumab by itself.
Okay, thank you.
We'll take any questions, and we're both going to be here, and everyone else in the audience will be here. We can also have a good discussion over some coffee, and then we'll reconvene in about 15 minutes. Is that how long? 10 minutes? 10-15 minutes. And then we'll have Steve Manning talk about his experience with Kidney Cancer Canada, and we'll have Flavio. Cannabis!
And for those of you that are online, we'll shut down the feed now, but we'll be back in 10 minutes. Yeah, but it will be back. Why don't you? I'll tell you.
I'm gonna try to plug my face. What?
Hi everyone, we're gonna be back in about 10 minutes. We'll shut it down. Try and get you a little bit more. Okay?
Yes, it will be available. Once the meeting is over, we're gonna